Is it clear now, sir?
I think, are you using two gadgets?
No, sir. Actually, I'm using only this thing, sir. I changed the settings.
Yeah, it's more of echoing. Echoing is there.
Is it clear now, sir?
Yeah, it's better, definitely better. Yeah. Shall we start the presentation, both of you, faculties?
Yes, sir. Yes, sir.
Yeah,
Yes.
yeah. I think let me start the introduction alone, that can continue with the discussion and presentation discussion also. Okay. So good evening and welcome you all for this API-ICP postgraduate virtual training program. We have with us two faculties from the Department of Respiratory Medicine, PSG Institute of Medical Science and Research. We have with the Assistant Professor of Department of Respiratory Medicine, Dr. Saravanan. It's also interventional pulmonologist. Really thank you, Dr. Saravanan, for accepting our invitation and being the faculty for this evening. And we have with us, Dr. Gayatri, who is a senior resident in the Department of Respiratory Medicine. Really, Dr. Thank you, Dr. Gayatri, for accepting our invitation and being the faculty for this evening. And we have with us presentation by Dr. Ajay, the postgraduate from Department of Medicine, PSG Institute of Medical Science and Research. Over to Dr. Ajay and Dr. Saravanan and Dr. Gayatri to take over the further proceedings of the session, presentation and discussion. A case of a respiratory system, more of pleural effusion. Over to faculties and the postgraduates, take over further proceedings. Thank you. Dr. Ajay, start presenting. Let Dr. Saravanan and Gayatri start discussing. And just a brief about the discussion, Dr. Saravanan and Dr. Gayatri, you can start discussing both history level, examination science level, and at the therapeutic level also, including the investigations. Because it's a medicine department case presentation, so you can understand it is not going to be very in detail about the therapeutics of pleural effusion, but definitely should discuss about, but we'll be discussing more on the historical aspect as well as the examination point of view also. That is clinical signs and symptoms also. It may not be that much discussed in MD respiratory medicine or DM pulmonology, but this is a slightly different way of looking at the perspective of looking at the exam point of view of medicine is concerned. Over to Dr. Saravanan and Dr. Gayatri, take over for the proceedings. Thank you.
Good evening, sir. Sir, is it audible, sir?
Yeah.
Yes, it is audible.
Good evening, sir. Good evening, all. Today, I'm going to present a respiratory system case presentation on pleural effusion. Sorry, sir, it's no. It's awesome. A 35-year-old male, Mr. N, residing in Coimbatore, civil engineer by occupation, belonging to upper socioeconomic class, with no comorbidities and habits, came with complaints of cough with scanty expectoration for 2 weeks, breathlessness, MMRC grade 2 for 2 weeks, evening rise of temperature for 10 days. The patient was asymptomatic 2 weeks back, after which he developed cough, which was scanty mucoid expectoration, non-blood stained. This was insidious in onset. There was no aggravating and relieving factors. There was breathlessness on exertion, grade 2 MMRC. This was insidious in onset, which was relieved on rest and not associated with chest pain, orthopnea, and PND. There was evening rise of temperature, which was low grade, associated with chills for 2 weeks. There was no history of nasal discharge, congestions, headache, ear pain, ear discharge, sore throat, postnasal drip, hoarseness of voice. There was no hemoptysis, chest pain, allergies, no palpitations, chest pain, giddiness, blurring of vision, orthopnea, PND, and pedal edema. There was no facial puffiness, decreased urine output, hematuria. There was no gastric symptoms like burning, epigastric pain, regurgitation of food, abdominal pain, no hematemesis, melena. There was no loss of appetite, night sweats, and weight loss. There was no yellowish discoloration of eye, and there was no morning stiffness, rashes, and joint pain. There was no previous COVID infection and contact with tuberculosis, and no recent travel and sick contact. Past history for the above complaints, he treated in a nearby clinic conservatively with antibiotics, especially with amoxicillin clav. There was no investigations were done outside, especially no radiographic investigations. He had no co-ops, no previous surgeries or blood transfusion, and no he received 2 COVID vaccinations. There was nil significant family history. Personal history, he was on mixed diet, normal appetite. There was normal bowel and bladder habits and no addictions. Occupational, he was a civil engineer and he had field works on and off, no pets rearing. To summarize, the patient was a 30-year-old male with no comorbs, no addictions, non-smoker, a civil engineer by occupation, presented with complaints of cough with scanty expectoration, which was blood stained, breathlessness on exertion, grade 2 MMRC, and low-grade evening rise of temperature associated with chills for 2 weeks. So, provisional diagnosis, the probable system involved is respiratory system. Anatomically, it looked like parenchyma more than pleural cavity. And etiologically, it was probably an infective origin. On general examination. Sir, can I continue, sir? Yes.
Yeah, you can continue.
Okay, sir.
So, I'll ask you one question. What are the causes of dyspnea in this particular patient? What do you think is the reason for dyspnea in this patient?
Any consolidations?
You think the parenchyma is involved. So, there is some parenchymal involvement. So, that is the reason for dyspnea?
Yes, can be, ma'am. Might be a
Okay.
cause.
So, this particular patient didn't have any symptoms pointing towards pleural involvement.
No, ma'am. There was no chest pain. There was no pain.
So chest pain is this probable symptom which is pointing towards pleura, right?
Yes, ma'am.
Okay. Okay.
General examination. After obtaining consent, patient was examined in a well-lit room in supine sitting and standing posture. Patient was adequately exposed. He was conscious oriented and comfortable. He was a thin build. Height was 192 centimeter. Weight was 70 kg. His BMI was 19. So vitals showed a pulse of 100 beats per minute. It was regular, normal volume. Blood pressure was 120/80 mmHg. Respiratory rate was regular, abdominal thoracic type. Saturation was 100% in room air. JVP was not visible. There was no pallor, icterus, clubbing, lymphadenopathies. No external markers of tuberculosis, malignancy. No signs of respiratory failure. On respiratory system examination, in upper respiratory tract, there was external nose was normal, no nasal flaring, nasal septum was centrally placed, no nasal bleed or discharge, turbinates were hypertrophied, no sinus tenderness, gum, buccal mucosa, lips and tongues were normal, no dental caries, no halitosis, no tonsillar enlargement, posterior pharyngeal wall was normal. Lower respiratory tract inspection. The spine was normal. Trachea appeared to be in midline. Apex impulse was not seen, not felt, not seen. No visible scars or sinuses or pulsations. No intercostal indrawing. Respiratory movements on inspection. On the right side, it was equal on all areas. In the left side, it was reduced in lower anterior chest and lower posterior chest. Palpation, the spine was normal, no tenderness. Trachea was midline in position. Apical impulse not felt. Transverse diameter was 29.5 centimeter. Antero-posterior diameter was 16 centimeters. Transverse diameter and AP diameter ratio was 1.84. Chest circumference. On expiration, it was 86 centimeters. Inspiration, it was 89 centimeter. Right hemithorax, 40 centimeter. Left, it was 41 centimeter. Chest expansion was 3 centimeter bilaterally. Spinoscapular and spinoacromial was equal.
How it is bilaterally 3 centimeters? See, the chest expansion is total is only 3 centimeters, right? It's the total chest expansion. You have to measure
Yes, ma'am. Yes, ma'am. Yes, ma'am. It was total expansion was 3 centimeter.
Okay, then you should also tell how much centimeters on each side, so that we'll be able to localize the lesion on either side.
It was mostly equal on both sides, ma'am.
Chest movements were diminished on the left side, right? That's what you told already. Like
Yes,
left lower hemithorax, the expansion is reduced, right?
Yes, ma'am.
So obviously the expansion should be low on the left side and should be higher on the right side, right?
Right side, yes, ma'am.
I think you should go back and check that so
Yes,
that
ma'am.
we'll
It
be
was
able to
reduced.
localize. Yeah.
Yes, ma'am.
Continue.
Yes, ma'am. Respiratory movements. On right side, the supraclavicular, infraclavicular, mammary, and suprascapular, infrascapular were equal. On the left side, it was decreased in the mammary and infrascapular regions. Vocal femmeters, on the right side, it were normal. On the left side, it was decreased in the mammary, axillary, infraaxillary, interscapular, and infrascapular regions. There was no tactile or friction femmeters, no tenderness over the chest and back, no rib crowding, no bony tenderness. On percussion, dull note was percussed on the mammary, axillary, infraaxillary, interscapular, and infrascapular on the left side. There was no shifting dullness or straight line dullness. Tidal percussion, a dull note was elicited. Trop space was dull. Chronic isthmus was resonant.
How did you percuss trop space? How did you localize trop space? Because how did you actually localize it?
Was between the sixth rib.
No, this particular thing which you are talking about, the pathology that you're talking about could be a collapse also. So the trop space could have been shifted upwards as well. So how do you actually localize trop space in clinical examination?
Ma'am, it is above the sixth rib and below the left costal margin, ma'am. No,
the idea of percussing trop space is to find out whether the pathology on the right side is supradiaphragmatic or infradiaphragmatic. Okay. So there are conditions like there will be fibrosis of the whole of left hemithorax. There are conditions like that which will cause pulling up of the diaphragm as well as the wall contents upwards. So how do you actually find out which is trop space? Like there's no point in percussing the abdomen, right? So what do you achieve by percussing the abdomen? There's nothing you will achieve by percussing abdomen. You just have to localize the pathology, whether it is supradiaphragmatic or infradiaphragmatic. How do you do that? How to percuss the trop space is actually you have to palpate the apical impulse, and one space below the apical impulse is where the trop space will be located. So that is how you should percuss. So if the trop space is actually not resonant or it is dull, it could be because of subpulmonic effusion, or it could be because of left-sided pleural effusion, or it could be some other some reason. Like you have to do the percussion like that. So if you are not able to locate the apical impulse in palpation, there is it's not possible to do the trop space percussion. Okay.
Okay, ma'am. On auscultation, right side was basically sounds. On the left side, there was decreased intensity over the axillary, infraaxillary, and infrascapular. regions, bronchial sounds in the infraclavicular and mammary regions of the left side. Vocal resonance on the left side, it was decreased in the mammary, axillary, infraaxillary, interscapular and infrascapular regions. There was absent breath sounds over the dull areas of the left lung. No bronchophony and egophony noted. On cardiovascular examination, S1, S2 was here over all auscultatory areas, no murmur. Per abdomen was soft, no organomegaly. CNS, there was no focal neurological deficits. So a final diagnosis of left pleural effusion, probably infective etiology with no respiratory failure was done. These were the investigation centers, sir.
So as per your clinical examination, you said there is a left side pleural effusion. So what are the positive findings? Can you just summarize only the positive findings?
There was decreased movements on the left side, especially mammary and axillary and interscapular and infrascapular regions on inspection. On palpation, there was decreased movements in the left side. On percussion, there was dull note in the axillary, interscapular and infrascapular mammary regions. Dull note on auscultation, there was dull note on this area, sir. Reduced breath sounds on the left side, sir.
So what's your differential diagnosis other than pleural effusion in this patient, based on your clinical examination?
Pneumothorax, emphysema.
Okay.
Empyema is nothing but infected pleural effusion. We want differential diagnosis, like other than pleural effusion. Clinical.
Fibrothorax.
You said there is dull notes, right?
Yes, sir.
Reduced breath sounds, right? So
Yes, sir.
expect in a fibrosis there is dull note and reduced breath sounds or absent breath sounds.
Fibrosis should cause volume loss, right? Is there any
Yes,
feature
sir.
of volume loss here?
No, sir. No, ma'am.
What other differential diagnosis will not have volume loss at the same time can have all these findings? Reduced movements on the left side with reduced vesicular breath sounds.
Hydropneumothorax.
Hydropneumothorax again is a pleural condition.
Okay, ma'am.
So you classify pleural effusion broadly, like empyema, hydropneumothorax, everything falls into pleural condition. Okay, so what other clinical broad spectrum diagnosis can you think of in this patient? So you said this patient had cough and breathlessness and no pleuritic chest pain, right?
Yes, ma'am.
So what was your first diagnosis initially?
Based on your history, you said there is more of a parenchymal than the pleural.
Yes.
In your clinical examination, you have more your points are directed towards pleural pathology than parenchymal pathology. So what made you think that is more of a pleural pathology than a parenchymal pathology? How you convinced in your examination finding it's more of a pleural pathology?
What type of bronchial breath sound do you expect?
Reduced.
What type of bronchial breath sound do you expect in a consolidation to be direct?
Tubular, ma'am.
Tubular is a high pitched or a low pitched bronchial breath sound?
High pitched, ma'am.
So that That's one thing you can tell as a differential factor. See,
Okay.
the pleural pathology, and there was no bronchial breath sound heard, and the intensity of the breath sounds were reduced. So that is the one thing which you can tell, which is positive, in which favors effusion than a consolidation. Okay.
Okay, ma'am. Okay.
You go. Like, is it okay to continue to investigations?
Yeah.
But,
Yes, sir.
please, Dr. Ajay, you can continue to investigations.
So on investigation, CBC was normal, RFT, LFT were normal, sir. ESR was 53. In sputum analysis and pleural fluid analysis, ADA was elevated, more towards exudative pathology, and uh, pleural fluid pleural fluid analysis, protein, glucose, and LDH were normal. ECG had a sinus rhythm, sir. Sorry, sir. Echo was not done here. I didn't, mistakenly it has been added, sir.
Can you please show the investigation values? Is it possible for you to show the values? Have you put it into the slides?
No, ma'am.
Okay.
I haven't had it.
Okay, so far with history and investigations, you have history and clinical examination and investigations. So, what is your anatomical diagnosis? What is your diagnosis based on your history, and with that, how much investigations helped you to conclude differential diagnosis? So, you had investigations now, so you can make a differential diagnosis. So, come again from the history. You narrow down with whether it is what pathology and this thing.
Okay, sir. So, yeah.
So based on history, you said more of a parenchyma and pleural than pleura, right? So,
Yes.
so whether it's an acute or chronic or subacute.
Okay, sir. So, a 30-year-old male, since a young male, presented with 2 weeks of 2 weeks of complaint. So, it will be a acute cause of pleural pathology due to the dull percussions and decreased air sounds on the breath sounds on the left side. Since he is an young male, it could be of mostly of exudative pathology, exudative pleural fluid pathology. It's pointing towards infective origin, especially tuberculosis. And also it had a evening rise of temperature, which more points towards infective pathology. And
So, what causes breathlessness in this patient, doctor? Like
You said
you have come to the conclusion that it is a pleural fluid. So, how can you associate breathlessness with pleural effusion?
and yesterday you can see this patient is having some moderate pleural effusion, right? So you said the saturation is completely normal. You said the saturation was more than 95%. So Dr. Gayatri is asking a question like why there is breathlessness.
actually, uh, the pressure effect of the pleural effusion on the left lung was the reason for breathlessness on exertion, sir. And even in the history, the patient was saying breathlessness on exertion was not regularly was there. It was on and off.
See, thing is, like, patients live even with lobectomy and segmentectomy and pneumonectomy, right?
Yes.
So, do you think that moderate pleural effusion could have caused breathlessness in this patient because of the compression effect on the parenchyma or something else?
You said compression. You are partially right.
Okay. Lung collapse above the pleural effusion.
So, Madam said like she said like patient is living with
Yes.
complete lobectomy, pneumonectomy. There is no lung at all. So there is no fluid or nothing compressing there, but 8 patients are completely fine. So now, what is the reason you think this patient is having breathlessness on exertion?
So breathlessness is actually because of the depression of the diaphragm. Okay, it's the compression on the diaphragm and on the chest wall, not on the lung parenchyma.
Okay.
Okay, so that is the reason why this patient must have had breathlessness.
So if the patient is having some desaturation or something, some abnormality other than breathlessness, so you should think about something else in this patient causing breathlessness and causing desaturation. Not alone, the pleural effusion alone will not produce that much desaturation. Even if it is completely collapsing the entire lung, entire hemithorax is wiped out also, this patient can have still normal saturation and only breathlessness. So if the patient still with the minimal pleural effusion, like moderate pleural effusion and significant desaturation, you need to think about some other pathology like embolism or some other cardiac cause causing the desaturation.
Okay.
Suppose this patient presents with copious mucopurulent expectoration. What do you expect? What is the differential diagnosis do you think of?
Bronchitis, bronchiectasis.
Yeah, what are the suppurative lung diseases, you know? There are 3 suppurative lung diseases. Name 3 suppurative lung diseases. Can you name them?
Bronchiectasis.
So your case, see, there is a pleural involvement, there is a pleural effusion. The patient presenting with copious mucopurulent expectoration. What do you suspect?
Any abscess, ma'am?
See, okay, lung abscess. Lung
Lung
abscess can complicate and can cause copious mucopurulent expectoration. Okay. You have said 2. One more.
Pneumonia.
No, I'm asking you, like, there is a pleural effusion which you see in the X-ray, but the patient is having copious mucopurulent expectoration. What do you think of? It could be a bronchopleural fistula. Okay, so that can cause pus accumulation in the pleural fluid, can cause copious mucopurulent expectoration also.
Okay.
What amount of pleural fluid is actually needed for you to make it out in a physical examination?
Mm. 200 to 300 ml.
Yeah, 250 to 300 ml. Very good. So what amount of pleural fluid can be seen in a chest X-ray?
In 300 ml.
So you can tell it like in different ways, like
Like
effusion causing in AP
in
view.
AP position and lateral position.
Okay.
In lateral position, it will be 50 ml, ma'am.
Okay.
In AP, it's
PA view.
BA 200.
So what is the amount of fluid which is needed to obliterate the CP angle, and what is the amount of fluid which is needed to obliterate the whole of the hemidiaphragm?
It's around 30 to 50 to obliterate the CP angle, ma'am.
No. So in a lateral view, if the CP angle, if the cul-de-sac is obliterated, posterior the cul-de-sac is obliterated, it is 50 ml. And in a PA view, if the cardiophrenic angle, if the costophrenic angle is obliterated, it is 200 ml. And if the whole diaphragm is obliterated, it is 500 ml. Okay.
Okay, ma'am.
What is the normal amount of pleural fluid which is seen in the pleural space in a normal individual?
Ma'am, it's 0.20 ml per deciliter. Sorry, per kg, ma'am. Point 0.20
0.1 to 0.3 ml per kg body weight. Okay.
Okay.
Okay, so we'll move on to the investigation part. So can you show me the X-ray? So
Yes.
you have a history, you have your examination finding, and you have your investigations. So can you read this X-ray? What are the findings in this X-ray?
It's a chest X-ray PA view. The trachea was on midline. Trachea is in midline. The CP angle and cardiophrenic angles are blunted. There's a on the left side. There's a meniscal sign on the left side. There are infiltrates on the right side of the lung.
So whenever you're reading a chest X-ray, you should always tell the penetration, rotation, angulation, and about the parenchyma on each side, and you should also comment about the soft tissue and the bony prominence.
Okay.
Okay, so is the trachea in midline? Are you very sure?
Slightly towards right.
Okay. So did you count the ribs? Whether the patient is having any emphysematous changes?
No, ma'am.
Hyperinflation?
There was
So
no rib crowding.
no, there is no rib crowding. I'm very sure
I'm
about
not
it. So we're not looking at rib crowding. Okay, you see the right lung, no? So you have to count the anterior ribs. So how do you say it is normal inspiratory film or it is hyperinflation, hyperinflated lung fields? How do you say that?
The number of ribs.
How many ribs?
More than 6.
Yeah. Sixth rib should intersect the middle third of the diaphragm. So that means it is normal inspiratory film. Okay.
Yes.
So if it goes any beyond, it is hyperinflated. So hyperinflation means the patient has some parenchymal abnormality, probably emphysema. Okay.
Okay.
So what are all the radiological types you can expect in a pleural effusion? Do you feel this? How do you say that this pleural effusion is not loculated or it is loculated? So what is the sign that you see when the pleural effusion is loculated?
It's D sign, ma'am.
Okay.
On the loculated effusions.
So this patient doesn't have loculation. How do you say that this patient doesn't have loculation?
There is a meniscal sign and.
How do you confirm that there is no loculation?
Ultrasound, ma'am.
Okay. Otherwise, if ultrasound is not available in your setup, you can take a lateral decubitus view of the X-ray. Lateral decubitus view in the X-ray, and you can look for loculation, whether the effusion is static or it is moving. Then you can make out whether it is loculated or not. Okay.
Okay.
So what are the causes of left-sided pleural effusion?
Pancreatitis, tuberculosis.
Tuberculosis can occur anywhere.
Pancreatitis, ma'am. Peritoneal dialysis.
How do you diagnose pancreatitis by pleural effusion with pleural effusion? Like, what is the test that you do to diagnose pancreatic effusion?
By tapping, diagnostic tapping.
Okay. What will you send?
This is amylase, ma'am,
Okay.
in the pleural fluid.
There are two types of amylase. You know about it? There is one amylase called salivary amylase. The other one is pancreatic amylase. Which one do you want to send?
Pancreatic amylase, ma'am.
Pancreatic amylase. What if the salivary amylase is elevated in the pleural fluid?
Rupture through
Very good. Esophageal rupture.
esophageal.
Esophageal rupture can also cause a pleural effusion on the left side, in which the salivary amylase will be elevated, whereas pancreatic amylase will be elevated in pancreaticopleural fistula. So other causes of left-sided pleural effusion.
Any trauma on the left side, ma'am. Malignancies.
Malignancies. Okay. So particularly left.
Embolus.
Particularly left. Embolism can occur either side. Malignancy can occur either side. Trauma can occur either side. Particularly left.
Any left-sided cardiac.
Left-sided. What happens when thoracic duct ruptures above the level of D2? Can cause left-sided pleural effusion. So, like I said, esophageal rupture can cause left-sided pleural effusion. Pancreaticopleural fistula can cause.
Okay.
What are the causes for right-sided pleural effusion? Specific for right side.
Hepatic hydrothorax. Liver abscess.
Sure, liver abscess. Okay.
Sir, sorry, sir.
Ruptured liver abscess.
Ruptured liver abscess. Hepatic hydrothorax. The tumors.
Okay, what tumor?
And ovarian tumors.
Okay. What's the name of the condition?
It's a Meigs syndrome.
Okay. Meigs syndrome, effusion is exudative or transudative? So direct malignant infiltration or
Exudatives.
What is the type of effusion you get in urinothorax? Whether it is an exudate or transudate?
Exudative, sir.
You're sure?
It's pneumothorax.
whether it is malignant or non-malignant.
So, urinothorax, sir.
No, in Meigs syndrome, you're saying it's exudate. So whether it is malignant or non-malignant.
Don't know, sir.
So it can be either, but usually it's not malignant, and we should send cytology and we should see this thing. And usually in initial stage it's transitive, and later stage it can be exudative. So ma'am was asking some question, right?
Yes.
Urinothorax. So she was asking whether it is transitive or exudative.
Transitive, ma'am.
Yeah, it is transitive. Okay, how like in patient with cardiac failure, if the effusion is initially transitive and it turns to exudative, how do you actually make out that it is not because of infection and it is because of diuretics?
Based on that albumin.
Albumin gradient. So gradient
Albumin
between
gradient.
what? Between what? What is the ratio between?
Pleural fluid versus serum albumin. Ratio is more than 1.
1.2.
1.2.
1.4.
Okay.
That is more sensitive. Okay.
Okay, ma'am.
So how do you do the tapping in this patient? So where do you do the tapping?
So ultrasounded guided, ma'am.
Ultrasound guided.
Ultrasound guided.
Okay. So what do you look for in the ultrasound? How will an effusion look in an ultrasound?
It's anechoic, ma'am.
Okay. Usually anechoic. What if it is chronic? What happens to the effusion in due course?
It's thickened, ma'am.
Okay. Thickened in the sense? There will be septations.
Okay.
Okay. So there will be septations which will become complex septated. Then it becomes homogeneously echogenic. So which means it is probably organized. So we can't do tapping. Okay.
Okay, ma'am.
Before proceeding tapping, so what is the single most clinical examination you do before tapping? So you have this X-ray, and you don't. Let's say you don't have an ultrasound to look for where to point and where to. Ideally, if you have an ultrasound, you should use ultrasound. But let's say you are not having ultrasound. So before tapping, so how do you confirm that I'm going to tap this area? Which clinical examination you will do, or you rely most? Like I just do this based on this clinical examination.
Percussion.
Okay. So if it is a dull, then you will tap in that area.
And that straight line.
So you will do percussion. Is that what you said?
Yes, ma'am.
Okay. So what are the differential diagnoses if you have a dull note on percussion?
Consolidation.
Okay.
Thick pleura in case of thick pleura.
Okay.
Any tumors?
Okay.
Mass lesions.
Okay.
You're saying mass lesions.
Mass lesions.
Okay.
And one more. Collapse. Collapse also can
Okay.
cause a dull note.
Okay.
So how do you differentiate? So when you have a dull note and percussion, if you do the tapping, what happens? What happens if you insert needle and consolidation and other things? You tell you what you will do as one single important clinical examination finding. So one single important clinical examination which you will do before tapping, which will confirm that it is an effusion and nothing else.
So you just say like you did the examination, right? So what there is auscultation, there is percussion, there is inspection, palpation, everything was there. No? So
Yes, sir.
think one investigation that you uh, will be doing before. So as you said, percussion. So Dr. Gayatri said like it can occur in other conditions also. So percussion is out, auscultation is there, inspection is there, palpation is there. So obviously we are not going to do inspection. So
Auscultation.
palpation and auscultation. So auscultation, what will you expect that? Reduced blood sounds. Reduced blood sounds will be there already in, as he said, there will be collapse, there will be mass lesion. So it will be still there. Any more? Anyone?
Bronchial sounds above the pleural fluid levels.
See, okay, I'll tell you what. See, whenever there is effusion, there is reduced breath sound, right?
Yes, sir.
Why does that occur, and why it does not occur in other conditions? Can you tell me what happens actually? See, when you auscultate over the trachea, what you hear is a bronchial breath sound. When you
Yes,
auscultate over the chest, what you hear is a vesicular breath sound. What is the difference between both in terms of pitch?
I mean, bronchial sound, the inspiratory and expiratory will be equal.
No. When you do the examination, I'm asking you as a person, when you auscultate with the state, how do you hear a bronchial breath sound and how do you hear it over the chest? Whether it is loud in the bronchus or it is anything else, like you want to tell, like, what is the pitch? Whatever you're hearing over the trachea is the tubular type of bronchial breath sound. Okay, it is a high pitched sound, and whatever you're hearing in the your normal lung is actually a vesicular sound, which is a low pitched sound, which is relatively low pitched when compared to the bronchial sound which you're hearing over the trachea. So what happens actually is the normal vesicular breath sound is produced by the attenuating effect of the normal lung parenchyma. Okay. So whenever the normal lung parenchyma is damaged or transformed into any other pathology, the normal vesicular breath sound gets lost. Okay. So whatever you are hearing will be more louder. Okay. So it is the bronchial sound which is conducted directly, and the attenuation which is caused by the parenchyma is lost. So that is how you hear a bronchial breath sound over lesions in the lung. Okay. Whereas you don't hear anything in a pleural effusion or a pneumothorax because the pleura is separated. The visceral and the parietal pleura get separated. And once it gets separated, there is no conduction of sound from the lung to the chest wall. So that's how you don't hear anything. Okay. So whenever you're auscultating the chest, so you said no percussion dull note irukku appadina, there are differential diagnoses for that. So if there is collapse with patent bronchus, there will be tubular type of bronchial breath sound. If there is a mass lesion, there will be some kind of bronchial breath sound. So if there is something else which is consolidation is going on, again there will be a tubular type of bronchial breath sound. So something is going on underneath, then what you hear is actually a more attenuated sound, like a high pitched sound is what you are supposed to hear. If at all you don't hear a high pitched sound, so if you are hearing like your breath, whatever you're hearing is actually much lower when compared to the opposite side. So you're hearing a normal vesicular breath sound, but with reduced intensity on the side of pathology means pleura is involved. Okay.
Okay, ma'am.
So that you can confirm, you can very well confirm by doing the VF and VR. Okay, VF and VR will be clear-cut evidence that pleura is involved, and both the visceral and parietal pleura are separated, and your breath sound is reduced, and some pleural pathology is ongoing. So when you do the tapping, you are likely to get a effusion. So in other terms, like if you are going to do, if there is a mass lesion, if there is a collapse with patent bronchus, or if there is a consolidation, there will be tubular type of bronchial breath sound with increased vocal resonance and vocal fremitus. So you are not supposed to aspirate in that particular patient. Okay.
Okay, ma'am.
You can same extrapolate that to a tactile fremitus also. Okay, same what she has explained, the same to the tactile. So you can combine these investigations and then you decide whether you put a needle or not. Okay, so what are the indications that you will do a tap in a patient? Pleural fluid. You said X-ray, there is a unilateral pleural effusion. So in any pleural effusion, what are the indications you will tap?
Any fever, sir, associated with any fever?
So even if it is
Breathless.
more than, let's say more than 1 centimeter or 2 centimeter effusion, then you do tap and you aspirate and you see the pathology. So I'll frame the question like in a bilateral pleural effusion, what are the indications that you will tap?
Mm,
Can you explain the
Exudate.
reasons? What are the causes for bilateral pleural effusion before going into the tapping?
Any congestive cardiac failure,
Okay,
nephrotic syndrome,
okay,
hepatic uh, hydrothorax, uh, thyroid hypothyroidism, um,
okay.
tuberculosis, sir.
Bilateral pleural effusion.
It would be mostly unilateral tuberculosis, sir. Malignancies,
Okay, malignancies of primary of lung or secondaries?
secondaries,
Okay,
embolism, thromboembolism.
okay. So let's say you have bilateral pleural effusion in these causes you said. So what are the indications that you do tapping in these patients? What are the three important clinical features that you are going to tap a bilateral pleural effusion?
Any fevers or like infective origin.
Okay, one.
Um,
Something pointing that it is not a systemic cause, it's a local cause. You said infection. So all the conditions you said earlier are mostly non-infectious causes. So if the patient is having any fever, then you might think the patient is having some infectious causes. So you are going to tap one point agree, and second point. Second point towards something happening locally.
Any autoimmune.
No, that's not systemic. So the first point you said it's a fever. So above the earlier causes you said are mostly non-infectious causes. So if there is any fever, then you think the patient having some infectious causes. So I'm going to tap it. Second point is pleuritic chest pain. So the bilateral pleural effusion, I think they will not usually have a pleural inflammation. So before the effusion, they will not have any pleuritic chest pain. So if the patient is having any pleuritic chest pain and patient is not improving with the treatment, you are that underlying condition like congestive cardiac failure or pulmonary embolism or any condition you said. So in these three clinical conditions, you should tap and you should do diagnostic and analysis. Okay, which side is more than you do, or you confirm with ultrasound where there is acceptations or anything like that in you do. Okay.
Okay, sir.
So you have a history, you have a clinical examination, you have investigations. Now you have tapped that pleural fluid. So can you tell me what are the investigations you will do when you do a tapping, or before you do pleural tap? What are the clinical things you will notice? What are the lab investigation you need to do a tapping?
PTI,
Time.
complete CBC, PTINR, serum LDH, serum protein, sugars, then pleural fluid analysis, uh, uh, pleural proteins, pleural fluid protein, glucose, LDH, ADAs, TCDC, and pleural fluid for cultures, gene expert.
So you can divide those things like pathological, microbiological, biochemical, and then cytology. Okay,
Oh.
so in pathology, what are the investigation you will send? It's TCDC.
TCDC.
In biochemistry, what is your important point to differentiate whether it is a transitive or exudative? So you send, what are the investigation you will send?
Serum protein, pleural fluid protein, LDH, and
what are the other biochemical tests you will send other than protein, albumin, LDH, pleural fluid?
bilirubin.
Okay, before bilirubin, there is one important point. Just you've been already be sending these investigations. Just remember and tell me what are the biochemical investigations. So you completed pathology, TCDC. Okay.
Yes, sir.
Then you are coming to biochemistry. So in biochemistry, you need to differentiate whether it's exudative or transidative. You already sent protein and pH. Okay. Then
Cholesterol, sir.
before cholesterol, we don't usually send cholesterol to every patient, but we do send this investigation to every patient. Which biochemical investigation? Basically glucose. Okay. Then
Okay.
after glucose, biochemistry, anything else?
Sir, ADA.
Okay, ADA. Okay, microbiology. What are the microbiology investigations?
Sir, cultures, gene expert,
Okay.
CBNAT.
CPNAT and gene expert both are same. Okay.
Yes, sir.
What else? You can send automated agriculture also. Then finally,
Ram staining.
okay. Then leave it microbiology. Then we'll send cytology.
Cytology.
Cytology. So based on these investigations, so how do you classify these pleural infections?
Transidative or exudative. We see for proteins in the pleural fluid and serum. If there are Light's criteria, sir.
Okay.
Based on Light's criteria.
Can you tell me the last criteria?
The ratio of pleural fluid protein and serum protein more than 0.5. If it is, and LDH ratio, serum and pleural fluid, if it is more than 0.6, it is towards exudative. And also the LDH, if it is about 2/3 of the upper limit of serum LDH.
Should the exudative effusion satisfy all the three criteria, or any one is enough?
1 out of 3 is
Enough. What does it mean actually? What pleural fluid protein indicates and what pleural fluid LDH indicates? Why it is high in the pleural fluid? Pleural fluid is supposed to be an ultrafiltrate of the serum. Why protein is high or why the LDH is high? Any idea?
based on oncotic pressure. Yes.
Yeah, why it increases on why protein should accumulate in the how protein enters into the pleural space?
The vascular permeability.
Very good. Capillary permeability causes it indicates when protein is high in pleural fluid, it means there is increased capillary permeability. How LDH comes in? LDH, why? What is the significance of LDH?
So,
LDH has a clinical role in managing pleural effusion. That's why I'm asking this question.
don't know, ma'am.
So when the LDH is very high, it means it is impending lung abscess. Okay, it means there is pleural inflammation. So increased capillary permeability causes increased protein, and increased pleural inflammation causes LDH to be high. Okay, so if the LDH is very high, it means the effusion is going to become an empyema. Okay,
Okay.
so you have to manage accordingly. It's a complicated effusion.
Okay.
Okay, so you said exudative, transudative. So what each investigation, pleural fluid investigation actually tells you, like if the counts, what about the TCDC? So what do you expect a normal pleural fluid counts? What will be the amount and what is the most common cell component?
Usually, it is macrophagic predominance
Okay,
normally.
okay.
If it is neutrophilic, it is of any infective bacterial infections. For lymphocyte predominant, it is of more of tuberculosis or uh, lymphomas.
Okay.
Mm.
What about counts?
Sir, sorry,
What
sir.
about counts? Like 1,500, 5,000, 10,000, like counts, total count.
It's usually less than 1,500 to 1,000.
Okay, so if the patient is having more amount of cells, means there is more inflammation. Okay, so when the patient is having more like 5,000 cells, 10,000 cells, and neutrophilic, as you said, it's more of an infection. When the patient is having lymphocytic, and it's more of a chronic pathology, which producing the fluid is staying for lot more time. Okay, so you said pathology is finished. Then now you come to the exudative and transudative. So what about this? We discussed about this. Lights criteria and also what basically lights criteria uh, tells you basically. So can it completely differentiate between exudate or transudate, or there is some if and buts?
Mm.
So basically, rights criteria is designed to catch all the exudates. There can be some transudates also, almost 20-25%. There, the transudates also positive for rights criteria. Like if the patient is a congestive cardiac failure, but you give diuretics to the patient, it gets concentrated. The protein stays there, the fluid drains out. So it can be still exudative, but the actual cause is transudative without any pleural inflammation, without any pleural infection. That can be exudative. Okay, so if the lysis criteria is positive, it mostly exudative, but sometimes it can be transudative. So if you keep the criteria very low, it will be more of a exudative. If you keep the criteria little high, the protein amount little high, it will be more uh, go towards transudative. Okay. So
Okay.
what about glucose? What do you infer? What do you expect the normal blood glucose, the normal full feed glucose level, and
Usually, it will be equal in the normal cases,
equal to?
equal to pleural fluid, and serum and pleural fluid be equal in glucose levels.
Okay. So what are the other interpretation if it is high or low?
Uh, Sir, if it is low in rheumatoid arthritis
Okay.
and lupus,
Okay. Our patient, do you expect this patient is having low glucose or high glucose?
high, high, sir.
Why high?
Was
So what will be the pleural fluid sugars level if the patient is having infection? What will be in empyema? What will be in pleural effusion?
reduced. It will be reduced than the serum.
Okay. So in our patient, you are thinking this is infective or non-infective. So do you think the blood
Yes,
sugars, sorry,
will be low. So infective. So
okay. So protein finished, then you said glucose finished, then other thing, ADA.
ADS.
Okay. before going into ADA, you said initially that I'll do cholesterol, I'll do some other bilirubin and all. So do you routinely do cholesterol and bilirubin in all your patients?
No, sir.
Do you do routinely albumin?
No, sir.
So in what condition you will do albumin gradient? Just now you have said before. In congestive cardiac failure, you will do albumin gradient at ICP like 1.4,
Okay, sir.
1.2 to 1.4. Okay. So
Okay.
ADA, coming to the ADA. So what is ADA?
Adenosine deaminase.
Okay.
That there are two types, ADA1 and ADA2. It's a purine it comes out of purine metabolism.
Why ADAs rise in tuberculosis? And what are the other differential diagnosis of raised ADA?
In tuberculosis, the lymphocytes gets activated, sir.
Okay.
So increased lymphocyte activation. So there is more ADA.
Okay. So lymphocytes will secrete ADA1 or ADA2, which will be more specific in tuberculosis.
ADA2.
Okay, which will be secreted by ADA2 is more specific. Usually it's monocytes.
Monocytes.
Okay.
Yes.
So what are the other differential diagnoses in a raised ADA?
Any malignancy, sir?
Okay, what malignancy?
Broncho.
Usually lymphoma. Okay.
Lymphomas.
So
Okay, sir.
where any infective condition where ADA will be raised?
Sir, sorry, sir.
Any infective condition where ADA will be raised. Okay, so now this patient is having this effusion. You decided to tap it. Okay,
Yes,
so
sir.
you aspirated. So what do you expect in this patient? The pleural fluid color, and based on color, how do you differentiate the pleural fluid pathology? Whether it will be like, can you elaborate?
Straw colored, sir.
Okay.
And, milky
Medium?
white in chylothorax.
Okay.
Uh, in emphysema, hemothorax, blood stain in hemothorax, blood in hemothorax, sir.
You said straw color. You said milky white. You said blood stained. And
pus, emphysema, pus in emphyema.
Okay, so in what all these conditions you will send ADA, and what all these conditions you will not send ADA? Four different colors, right? So in what are the conditions you will send ADA, and what are the conditions you will not send ADA?
In straw colored, will send, sir.
Okay.
And hemothorax will send. We won't be sending in emphysema, sir.
Why you send in hemothorax? Basically, you not diagnose. Basically, you not diagnose based on color whether it's a hemothorax or not. Okay, you'll aspirate. You'll see a hemorrhagic color. You don't know whether it is hemothorax or hemorrhagic fluid effusion. Then you do certain investigations to confirm it's hemothorax. Okay. So basically, what I'm trying to say is, in empyema or impending pus, you should not send ADA. Okay. So it will be spuriously raised, and you might think it's tuberculosis. Okay, so if you see this looks like more of a straw color, it's not pus, it's not impending pus, then you can send ADA. Otherwise, you should not. If it is a pus, you should only two investigations. That is microbiology and cytology if needed. That's it. Okay, no counts, no other glucose or this thing, because already it's pus, right? So why you want to differentiate whether it's a transitive or exudative counts and all. So if you aspirate a pus, you send only for culture, gene expert, plus or minus cytology, nothing else. Okay.
Okay, sir.
So coming to next investigation. So you said ADA, then after that, what are other investigations? Microbiological investigations. What do you expect? You said like you'll send this gene expert, you'll send bacterial culture, gram stain, automated apiculture. So do you really uh, uh, in a country like India where that's a TB is endemic, so where everywhere every sample we are sending gene expert, do you need to send pleural fluid gene expert to all patients or any selected population, selected high risk population you need to send? See, if we are in a private institute, then we need to send. Okay, if we are in a government institute, if you are in a high volume center, if you tap each and every plural, well, let's say you are tapping around 5, 6 plural tapping a day. So you send every patient plural to Indian expert, or you send to a selected patients. If so, what are the selected patients?
Young patients,
Okay.
mostly of unilateral effusions.
Okay. So let me reframe my question. What is the sensitivity of plural fluid gene expert?
Less sensitivity, sir.
Less sensitivity.
Yes, sir.
Okay. So which sample has more sensitivity?
And, ball samples, sir.
Okay.
What do you think is the actual pathophysiology of pleural fluid in tuberculosis, doctor?
Hypersensitivity.
Yeah. What are the other hypersensitivity like tuberculosis hypersensitivity manifestations in any individual? Like pleural effusion, like what are the other manifestations you know of? You've ever heard of lictenellar conjunctivitis?
Yes, yes, ma'am.
That's a hypersensitivity reaction. So, is
Hypersensitivity.
there any need to treat these patients? It's a hypersensitivity reaction. So, it means our
No.
body is reacting to the tubercular proteins. It's not the infection per se.
Okay.
What is the need to treat? Is there any need to treat?
Yes.
Why? How do you treat? It's a hypersensitivity reaction, no? So, you give steroids or give ATT, or you give both.
ATT, ma'am. Give
Why ATT?
to
You
treat
clearly
the.
are not isolating any bacilli ever in a pleural fluid, right?
Yes.
So it's only a protein, tubercular protein, which enters the pleural space, which is causing the hypersensitivity reaction. So just like in what you have presented in your patient is a young person without any comorbids, without any risk factors. What do you think must have caused the effusion? And do you think it is really is there any need to treat? And what if you don't treat? What happens if you don't treat?
Progression into extrapulmonary TB.
Extrapulmonary TB. See, a sole pleural effusion is not communicable. You know about that? The patient with pleural effusion coming to you, if it is only a pleural effusion, there is no parenchymal abnormality. That patient cannot spread the disease. So how do you think he will be spreading it to his own body, like manifest as extrapulmonary tuberculosis? So what happens if you don't treat a tubercular pleural effusion is that there will be spontaneous resolution of the effusion, but the chances of relapse in future are very high. So that is the logical reason why we are giving anti-TB treatment instead of steroids in these patients.
Okay.
There is some immune compromise which has caused a few proteins to enter into the pleural space, manifesting as effusion. So they may go on to develop full-blown pulmonary tuberculosis or disseminated tuberculosis, any for that matter. in future. So that is the reason why we are treating the patient with anti-TB treatment. Okay.
Okay.
So, in a resource limited setting or in a high volume center, you will not do CPNAT or a gene expert in the pleural fluid. Okay, but if the fluid is more towards like a pus or exudative, or is there any septations in the ultrasound, or if the patient is a retroviral positive patient, so the yield is much higher. The pleural fluid gene expert yield is much higher. So instead of there is a hypersensitivity reaction, there is much more of a pleural fluid, full-blown tuberculosis, bacterial infection. So in those cases, you can send a pleural fluid gene expert, and it can be positive. Okay, if the pleural fluid gene expert sensitivity is very low in pleural fluid, but specificity is very high. If it is a positive, very unlikely there will be another cause. Okay, so that's why you have to send associated automated culture also to see whether the actual bacteria is growing or not. Okay, so after that microbiology, you will send your cytology. So how many ml usually you send for cytology? What is the minimum amount of fluid that you send to the lab, cytology lab?
20 ml.
Right?
20
20.
20 ml.
At least 30 to 50. At least 50 ml. 50 ml is ideal.
Good.
Okay,
Okay.
so you send for cytology to identify. So what will be identify in cytology?
The cells,
What kind of cells?
cell blocks, sir, lymph, malignant cells,
Okay.
uh,
You can see malignant cells or lymphocytes or neutrophils or something else like that. Okay, so
okay.
based on these investigations, you will differentiate whether this patient is having exudative or not, whether it's an acute or chronic, whether it's neutrophilic or lymphocytic, whether it is a low ADA or ADA, whether it is an acute inflammation or chronic inflammation, whether it is sterile or not sterile. Okay, so these are
Yes.
the 5 information you will get with pleural fluid diagnostic tab. Okay, so
Okay.
these investigations usually give you much more information what is underlying pathology. But sometimes you will send some extra investigations like cholesterol, like triglycerides to see whether it is Kyle or something. Okay, so it's based on how you aspirate, or like how what is the color of your fluid, what is the consistency, like you said, milky white. So in those conditions only you will send those kind of drugs investigations. Okay. So other than this, you will not usually send cholesterol or bilirubin or whatever the things. Okay.
Yes.
So you aspirated diagnostic pleural fluid. What can you tell me? What are the findings in this patient?
Sir, the ADA was elevated.
How much?
Sir, it was 61,
Okay. What is the
uh,
normal cutoff value?
less than 40.
Okay.
Protein, glucose, and LDH were normal in the normal limits, sir.
Okay, normal means whether comparing with the so you should not say normal in this condition. You should usually say whether it's an exudative or transudative. So that
It's an exudative things.
exudative. What is the LDH?
Sir, 1 second, sir. Sir, pleural fluid LDH was 382, sir.
82. Okay, so you have one information high ADA, you have two information exudative. Then other than that,
Fluid protein was 4.88, sir.
okay, okay. Then
Glucose was 88, sir.
okay.
Uh,
What is your cytology finding? What is your gene expert finding? What is your TCDC?
Gene expert was negative, sir.
Okay,
And cytology, there was lymphocytosis, sir.
okay.
Lymphocytosis, yes, sir. It has marked cellular showing sheets of lymphoid cells, sir.
Okay, so in this situation, you did an diagnostic oral tab. You have all the reports now. So will you do a CT in this patient, or you will just go for the management part?
Uh,
Will you do CT or any more investigations, either clinically or radiologically or microbiologically, or you will directly go for the management of?
There's no need for CT, sir.
Okay.
Uh,
Why do you think there is no need for CT in this patient?
First, it's an unilateral
Okay.
young patient,
Mm.
and there was no malignancy symptoms and signs, and it's of exudative. It's
So you are right only. So usually you don't need to go for a CT in this patient. So unless you find any lymph node, you find any strong smoking history, you find any old age people, or you find any other organ symptoms, you think this is a secondary. So you don't need to do. But based on clinical decision only, and as well as the pleural fluid is strong color, and you have strong evidence of ADA is high. So in those conditions, you don't need to go. But when you think the pleural fluid investigations and the clinical picture is not suggestive of this thing, then you go for a CT. So let's say you aspirate this patient, you first scan. Okay, so what will you do? In those situations, will you go for a CT or will you do only management part?
We'll do CT, sir.
Why you want to do CT when you aspirate first before management?
To localize abscess.
You think abscess and ruptured into this pleural cavity, we want to treat this thing. So again, clinically you have to think. So in this patient, everything you forget about the investigations part. So all the history, 2 weeks of history with cough and sputum, and you have this X-ray, you have spread pus. So what do you think? What is your differential diagnosis? You already said lung abscess.
Yes,
Okay.
sir.
So will you do ICD or will you do CT then ICD?
For culture.
What is undiagnosed pleural effusion?
No, no, sir.
So when you don't have any evidence of tuberculosis, when you don't have any evidence of malignancy, and you have only exudative and you couldn't find anything, that those situation only you have to go for a CT. Okay. So
Okay.
why there is a need of CT? What you are going to do? What is your next step after CT? What will you look in CT? What are the differential diagnosis that you look in CT for an infection? Sorry, what are the differential features in CT? You look in infection, you look in malignancy, or you look in tuberculosis. So your ADA is low. The same patient ADA is not 60, it is 20. Okay, it's exudative. The counts are 2000, 2500. And cytology, they said is a chronic inflammation or acute inflammation, acute and chronic inflammation. And your sugars are around 40, 50, around almost equal to this thing. So now you are doing a CT. So what will you look in the CT? What CT you will do in this patient? Will you do HRCT or will you do a contrast CT?
Contrast.
Why you want to do a contrast CT in this patient? What is the exact point you need a contrast CT in this patient?
Any nodals?
Okay, mediastinal structures. You want to see the mediastinal structures. Other than this, any particular to pleural pathology?
Pleural nodals, sir.
Pleural nodules. Other
Pleural
than that,
nodals.
so you
Thickening of.
you want to see thickening and pleural enhancement. Okay, so so based on that thing, that is the only thing you want to see in pleural in contrast CT. Okay, So usually in infection, you will see whether it is a localized empyema or whether it is lung abscess causing this thing and all. But nowadays you can easily differentiate with ultrasound, but still it's better to do a CT before proceeding for any further this thing. Okay, in a malignancy, you will see nodularities. Okay, nodularities in the diaphragm, nodularities in the pleural surface is highly suggestive of malignancies, malignant etiology. And then in infection, there will be usually pleural enhancement will be there, and there will be septations will be there. Okay, so when you do a CT, you need to know what you would look for, whether it is towards malignancy or infection or any pus empyema like encysted empyema like this. So coming to the tubercular pathology, here as ADA is high, so which investigation is most sensitive to identify local lesions, whether it is CT or ultrasound. You have ultrasound with you, you have CT with you. Which investigation you will choose to see any septations or local lesions?
Ultrasound.
Ultrasound, okay. So we have tabbed it. You said the pleural fluid is more towards tuberculosis. So what you are going to do next?
ATT, sir. I will start.
Patient is having massive pleural effusion, right? So why can't drain it further?
I see.
So you will drain.
Okay.
No, I'm asking you, will you drain or will you not?
Yes, sir.
You will drain.
We will drain the
Why you want to drain?
actually. It will progressive increase in the and breathlessness. It will worsen the symptoms.
So if it is a tubercular pleural effusion, you don't need to drain. Okay, so you just start ATT, whatever it is, just leave it, and the patient will uh, get benefited. No need to drain in a tubercular pleural effusion. No need to do any furthermore if you confirm the patient is tubercular pleural effusion. Okay, so in our history, the patient is having only 2 weeks of symptoms. So based on that thing, do you still think it's tuberculosis and you let it? Uh, you start ATT and you will continue, or you will drain further, thinking some other differential diagnosis. So only 2 weeks of symptoms, right?
Yes. Any
What is the gold standard investigation for tubercular pleural effusion? The gold standard investigation tubercular pleural effusion is actually pleural biopsy. But you don't need to do pleural biopsy if the ADA is still high, as our country is a highly endemic uh, for tubercular, high prevalence for tuberculosis. You don't need to investigate further. But when the ADA is in the borderline, when the ADA is low, then you do CT, then you subject the patient for a pleural biopsy. Okay. So, as I said, CT you have to look for whether it is towards malignancy or towards infectious pathology. If it is infectious pathology, then you go in a different line. Okay, and it is a uh, uh, malignant etiology like nodules, mediastinal pleura involvement, those conditions you go for further investigation. So, what are the modalities you do pleural biopsy? If it is a malignant, you are suspecting there is some nodules in the pleura, in the mediastinal pleura, in the diaphragm and all. So, what investigation next you will do to confirm your diagnosis?
PET CT.
You will do a PET CT. Okay. What do you expect in a PET CT?
Increased uptake and
Uptake in the
uptake pleural
okay.
cavities.
Okay, so you proceed for what investigation?
And then biopsy.
Okay, so what biopsy you do?
Cell plural.
Pleural biopsy. So what medical thoracoscopic aided pleural biopsy or blind pleural biopsy? So usually you do medical thoracoscopic aided pleural biopsy to identify the nodularity. Let's say you said, as you said, PET investigation. You don't need PET actually here. You can directly go for this thing. So let me ask you a question. So if there is no uptake in the pleura, okay, in PET CT, so will you still choose pleural biopsy?
No, sir.
You will do some other investigation. Let's say there is no other involvement, no other PET uptake anywhere in the body. There is only collapsed lung, and there is your pleura where there is no uptake. Okay, so we don't have any nodularity, we don't have any infectious thing like ancestor pleural or thickened pleura, thickened vessel pleura like that. Still, you choose to take pleural biopsy or you do some other investigation. So even if there is no uptake in the pleura in PET CT, you can definitely go on take pleural biopsy even if it is malignant. Okay, so there is no hard rule that only there is any uptake then you should do biopsy. Otherwise, it's not like that. So you can. There is definitely there are multiple causes for proliferation in a malignancy. So if there is no other area, no other mass lesion, no other peripheral lesion that you couldn't access, then you can definitely go for a pleural biopsy. Okay?
Yes, sir.
Medical purpose. So let's say this is not going towards malignant side, it's going toward infection side. Let's say it's a pleural efficient, they have reported as an empyema. So what will be your treatment?
Antibiotics.
Will you choose to drain the fluid or just leave it like that?
Will drain.
Why you should drain?
Will pleural thickening and
Anywhere there is pus collection, you have to drain it. Okay, so that goes true for lung also. If there is pus in pleural space, you have to drain it with pigtail or a wide bore ICD. Pigtail usually will get blocked, so you have to go for an ICD if it is an empyema.
Oh.
Madam said there is no need to if even the fate of pleural efficient, tubercular pleural efficient in hypersensitive reaction, you just leave it, it might resolve. Okay, so what if a pus, if the pus and you just let it not, like you are not draining it. So I said tubercular pleural efficient, you start ATT, you don't need to drain. If it is a pus, if you are not draining, so what will happen?
Thickening, pleural thickening with the sir.
Okay. It will go for fibrothorax. Pleural thickening will be there, and you will not drain it further. It will go for thickening, and your lung will be completely, what to say, completely shrunken. Okay, so it will go for a restriction of normality. So anywhere it's first, it should be drained. But no tubercular pleural efficient, you should not. You don't need to drain. Usually, you can drain, but you don't need to drain. Okay, so if you instead an ICD, you drained everything, then still you have a doubt whether it is, you don't know whether it is a tubercular pleural efficient, whether it is a some bacterial infection or something. Okay, sorry, this thing pus. There is a pus, and you put inside an ICD. Pus came out, but still you have a doubt whether it's a tubercular or whether it is a bacterial. So what will you do? How will you confirm in those situations? Like you have a dilemma whether to start ATT or just treat like a bacterial infection. So what will you do in those situations? How do you confirm whether it is tubercular or not tubercular?
Cultures.
Okay, cultures are negative for tuberculosis. There is genus but is negative, AP stain is negative. For automated AP culture, let's say 1 week there is no growth. So still, will you start ATT for this patient, or will you treat like a bacterial infection and you remove the ICD once it gets improved.
Empirical ATTs.
You use the empirical ATT or you treat like a bacterial infection? Again, it's based on your history only. So patient, if there is only very short history, underlying patient is having uncontrolled diabetes or something, or is an alcoholic, if you think the patient is having much more low platelet pleural collection, then you can definitely treat the patient for bacterial infection. And if it is not improved, you go for a biopsy. Okay, you don't start empirical ATT in this, okay, because you have a plenty of this thing. You have a gene expert, you have automated agriculture, you have everything, you have. So we should not start every empyema ATT. We should go for microbiological investigation to confirm microbiologically whether it's tuberculosis or non-tuberculosis. Then only you have to go for initiating ATT. So unless proven otherwise, you should not start empirical ATT. Let's say this pus is not resolving, like 1 week or 2 week or 3 weeks, it's not improving at all, and you can see some consolidation in the HRCT or CECT lungs. Then you go and find what is the investigation. You send a sputum investigation, you do a ball from that area to find whether it's a tubercular or not. Okay, so empirical ATT in an empyema is now we will not usually do. We should wait for at least 2 to 3 weeks because empyema of what is the duration of antibiotic you should give in a empyema patient. It's actually 3 weeks. You should give antibiotics for 3 weeks. If after 3 weeks the patient is not improving, the patient developing some other continuous symptoms like fever, loss of weight, loss of appetite, and long-standing symptoms, then you can think like HIV patient or something. Then you can think of starting ABD. In those conditions, also still you have to find your microbiological evidence for tuberculosis. Okay.
Okay.
Okay. So you have empyema part over, tuberculosis part over, then other malignancy part over. Then what about this other pleural effusion condition? So this patient had parenchymal lesions. You said the patient is having cough and mucoid sputum and 2 weeks of this thing. So the same patient, if the ADA is very low, like 10 or 15, same exudative, same inflammation. So what it could be your differential diagnosis?
Connectivity disorders.
No, patient is having only 2 weeks of symptoms.
Okay.
30-year-old non-smoker. He's having cough and sputum. He's having this X-ray. You aspirated. ADA is slow, and your exudative. Other investigation pointed out it's exudative. Let's say it's lymphocytic or neutrophilic, anything. So, what is your differential diagnosis? Same patient, except ADA is low. There is no malignancy. There is no pus. What is your differential diagnosis? You said patient had fever and chills and all, right?
Yes. Pneumonia causing pleural effusion.
So what effusion? What is the name of the effusion? Pneumonic effusion or parapneumonic effusion?
Yeah.
So
Yes, sir.
will you drain it?
No, sir. We'll treat the cause and.
So parapneumonic effusion, you will not put a pigtail or ICD. You will just treat the antibiotics. So what will happen if you didn't drain it?
It will resolve. It will resolve once the trigger is settled, sir.
Okay. What is the trigger?
Pneumonia, sir.
Okay. So you will treat the pneumonia, but you will not drain the pleural effusion. So what will happen? the same X-ray. So if the patient is having a pneumonia, underlying pneumonia, and with the same X-ray, like this is moderate pleural effusion, right? Usually
Yes.
you should drain. Along with antibiotic, you should drain. So
Okay.
you have to look for the cultures. You have to look for other biochemical investigation. Whether the even if the ADA low, you have to look for whether it's neutrophilic, the sugars are less. You have to think whether it's going for a complicated pleural effusion. Okay.
Okay.
So pneumonic efficient usually go for a complicated pleural effusion where there will be septation, where there will be pus intake on all. Okay. So in those situations where the patient is symptomatic or where the patient is having this much pleural effusion, usually you should drain along with antibiotics. Okay.
Okay.
So uh, what is the antibiotic of choice if it is a pneumonic pleural effusion? Otherwise, what are the organisms that cause pneumonia and pleural effusion? Pneumonic pleural effusion.
Streptococcus.
Okay. Okay. These are basically Staphylococcus, and these organisms. When you go for when you think about empyema, it's usually anaerobes. Okay. So when the patient is having any pus or any purulent thing, you have to go for an anaerobic cover also. But when you think about only communicated organisms and it is not pus, you can simply stay with broad spectrum antibiotics like ceftriaxone or amoxicillin acid. Just treat like a cap. You don't need to give a separate antibiotic cover. Okay, but if it is turning into a pus or which looks like a frank empyema, then you should definitely cover an anaerobes like metronidazole or clindamycin, which has a much more volume of distribution in lung, much penetration in lung. Okay, so you should choose either one of the drug along with the actual beta broad spectrum beta lactam BABL drugs. Okay. So
Okay.
if it's a tuberculosis, you don't need to drain it. You just start ATT and you go. Proven it's not us. Okay.
Okay.
So how many days you will give antibiotic in a parapneumonia patient? Let's say you have the culture of something sputum has something bone like streptococcus, and you have an effusion, this much effusion. You insert a peptide, your culture and is sterile, but your glucose is low. So you inserted and you started antibiotics. So how many days you will give antibiotics for this patient?
2 weeks.
2 weeks. So actually, in a parapneumonic effusion, you don't need to prolong it. You just give a 7 days antibiotics. It is a pus, give 3 weeks. Okay. If it is tubercular, no drain, only ATT. So you understand, right?
Yes.
Okay. So in infectious part, what are the classification of pleural fluid? Pleural fluid, like, uh, classification of complicated and pleural empyema. Complicated to Light's classification of
Parapneumotic effusion.
parapneumonia effusion. Exactly. What are how many classes are there?
I don't know.
No.
7 classes are there. You just go ahead and read about it. Light's
Ah.
classification of parapneumonic effusion.
Okay.
So based on that thing only. So whether it's a class 1 or class 2, class 3. So as soon as you tap it, you fix it which class the patient comes. Okay. If it is more higher classes like class 4, class 5, class 6, you have to definitely drain it. If it is lesser than the class 1 or class 2, we don't need for drainage unless the patient is symptomatic or large effusion. Okay. So based on whether there is a if there is a gray area whether you drain it or not drain it, you use the classification. You based on the investigations like you said glucose and all, you can add actually pH also. Okay, so based on that readings you decide which class of pleural effusion and you decide whether to drain it or not. So is there any role for surgery in this patients?
Sorry.
Surgery. So actually, in some cases like ancestor pleural effusion, low-level pleural effusion, where medical thoracoscopy will not give you the clear thing in an young patient, you can go for a surgical VATS also. Okay, so there is no clear-cut definition or timeline where you should have, earlier you should do VATS or later you should VATS. Okay, so when there is a much more complex pathology inside the pleural cavity, then you go for VATS, you decorticate entire thing, and then you go for nicely drain that. Okay, or if it is a tuberculosis where there's a persistent air leak, the patient is not improving at all, patient is having complete pus, then you can go for after initiating ATD, the patient is still not improving, then you can go for a surgical. Okay.
Okay.
Can you ask some more questions?
We'll finish soon.
Yeah, myself. Okay, you can ask some more.
Yeah, I have nothing. Only about the ATT. There are 4 drugs, as you know. So we'll initiate with the drug-sensitive ATT for any pleural effusion. So since there is no microbiological confirmation, like the gene export is obviously negative, so you will treat it as tuberculosis hypersensitivity reaction. And continue ATT for 6 months and watch for resolution. That's all.
Okay.
Okay. I think we'll finish.
What's the final diagnosis of this patient?
Left-sided pleural effusion. Exudative type of pleural effusion, probably of infective origin. Most likely it was tuberculosis.
So your workup has been completed, or still you want to work up for some more? So you have an young male, otherwise healthy male, 2 weeks of symptoms, presented with this much effusion, in diagnosed in pleural tuberculosis. So you just treat the tuberculosis, or you work up for something else. You have to think why this patient had a pleural. Yeah, so you have to think why this patient had a pleural effusion. So you need to look for any underlying immunosuppressive condition, immunodeficient condition that lead to tuberculosis in the patient, and you have to look for other risk factors of tuberculosis in this patient, like overcrowding, any malnutrition, or any uncontrolled diabetes, or any serology positive status. Okay.
Yes, sir.
Exactly. And okay, you want to ask any more?
Sir?
Do you want to ask any more questions?
Okay. No, sir. That's all. We'll finish.
Yeah. Completed, Dr. Gayatri and Dr. Saravanan? Completed,
yes,
or yet to?
Yes, sir. Fine, sir.
Yeah, I
You
think I'd
want
like
to
to give some. Yeah, really thank you, Dr. Gayatri and Dr. Saravanan, for wonderful discussion, especially on the basics of investigation related to pleural effusion and different types of pleural effusion, and touching upon the important aspects of clinical tips related to the different conditions, putting similar findings, and how to differentiate, especially differential diagnosis has been discussed, and bit of elaborate on the discussion on the therapeutics also, especially management of pleural effusion, and touching upon the ATT part. But I would like to give a tip to Rajay postgraduate. Nearly you have wasted your time of 22 minutes by keeping quiet, Dr. Rajay. Out of these 1.5 hours of discussion, when a question is raised to you, you just kept quiet. You don't know whether you know the answer, you don't know the answer.
Sorry, sir.
Are you there?
Yes, sir. Sorry,
Yeah,
sir.
if you're asked a question, you should say yes or no. So this is a platform where you're going to make all the mistakes so that you don't make the mistake in the examination. That's the basic idea of this type of platform.
Okay,
And
sir.
just keeping quiet and silently is not a way of answering a question, especially at a level of postgraduate.
Okay, sir.
And a few areas of basic questions you're not even able to answer in a flow manner, which is what expected from postgraduate level. You should talk in a very flow manner because it's basically an undergraduate question and should be able to answer in by undergraduate very interrupted manner. But postgraduate should talk in a flow manner or fluently, which you have not done it. That means what I understood, I don't know about other faculties, the assessment of this candidate. I would say you're not prepared well for this topic. Even though you examine the patient, you're not prepared the slides properly, not even investigations. Why it's not included in these slides? You didn't find time to do that?
Sorry.
Once again, keeping quiet.
Mm.
This keeping quiet, the examiner also will keep quiet. In the sense, he will not put his pen into the mark sheets. Is it okay for you?
No, sir.
Why? You want to keep quiet and you want the examiner to put marks for you in the case sheet, mark sheets?
Uh,
Why you not prepare the slides properly, Dr. Ajay?
that's,
Already
sir,
mentioned
examination.
clearly that how the slides should be designed.
Yes, sir.
Doesn't require a supervision. Grown-up boys and girls doesn't require repeatedly keep on running behind just did they work or not. Nobody is there to do that. You should have your own responsibility, which is not done by you properly. Sorry about that, but you're not up to the mark. The presentation, the quality of slides. Somehow the faculties are generous enough to teach you also. Really appreciate both the faculties for this generosity of teaching you. Even though you're not in a flow manner of presentation, the slides are not up to the mark. You're not a single investigations. Everything you say normal, but no values of this patient. How do you expect the faculties to discuss about the case then? Who are the postgraduates going to present next 4 weeks? I don't want them to make the same mistake. Really, thank you, Dr. Gayatri and Saravanan, for wonderful discussion on these different aspects of presentation. Dr. Ajay, you have to improve a lot.
Yes.
It's not up to the mark, not even to the basic level. Okay.
Okay.
If you really want to survey, you have to improve a lot. Okay.
Sorry.
And thank you, every one of you, and good night to all of you. Thank you.
Thank you.
Thank you.
Thank you. Thank you, ma'am.